Hello, everyone. We are back with our next session on supporting sexual health for the colorectal cancer patient, and we are welcoming Dr. Ann Katz as our expert presenter for this session. As a certified sexuality counselor, registered nurse, and author of 16 books, Dr. Katz brings a rare blend of clinical expertise, compassion, and deep insight to some of the most intimate and often misunderstood aspects of human health. With a respected reputation as a leading voice in cancer and sexuality, her work empowers individuals and couples to reclaim their sexual well-being, even in the face of illness and major life transitions. Her credibility is rooted not just in her extensive professional qualifications, but in decades of thoughtful advocacy, evidence-based education, and the ability to create safe, affirming spaces for honest conversations. She is known for her warm, no-nonsense approach, blending science, sensitivity, and a strong ethical compass to support both clients and the broader medical and nursing community. So a very warm welcome to you, Dr. Katz. I'll pass it over to you to get us started.
Thank you so much. Let me do this. Here we go. I think this might work. Woo! It
Yeah,
worked.
looks great.
You never know. So, good afternoon, everybody from sunny but cold Manitoba. I don't know. Spring, somebody said to me, spring's supposed to be around the corner. I said, yeah, but it's 5 blocks away. That's where the corner is. So we are still suffering. I hope it's warmer where you are. So I'm really happy to be here. I'm going to be speaking for about 40, 45 minutes and then answering questions from the coaches, which is always the fun part for me. So, coaches, write down your questions. There is nothing that I haven't, well, there's some things I haven't heard, but I've heard most things. So don't be embarrassed. Don't be embarrassed about the words you use. It's all fine. So, um, this is a busy slide. My apologies. I generally don't have busy slides. But this is just to, reinforce that sexual problems are extremely common after cancer, all kinds of cancers. So, if you were interested, you could say, well, tell me about, hematologic cancer, or tell me about bone cancer, and I'll have an answer for you. I've been doing this work for 26 years and I've seen literally thousands of patients. So sexual problems are really, really common. In the context of colorectal cancer, many of you have been through this. Surgery, radiation, chemotherapy, um, for some even immunotherapy. So we tend to throw the book of treatment at people with colorectal cancer. And many people have multimodality treatment, which just tends to put problem upon problem upon problem. So almost all men treated with multimodal therapy report erectile dysfunction. In part, it's physiological, in part, it's anatomical, but there's also a huge emotional piece. Because performance anxiety is real. It's real for all of us. And, the mind, we always say the brain is the biggest sex organ. Yeah, I've never seen a penis the size of a brain, but that's besides the point. Um, so erectile dysfunction extremely common, and in women, what we see is dyspareunia, which is a Latin word for vaginal dryness, also vulvar dryness, quite frankly. But basically, dyspareunia means painful penetration. I absolutely acknowledge that penetration is not it for many women for many different reasons. They may have a partner who is not fully capable of an erection. There may be a woman who has sex with women where penetration is just not something that is part of their sexual repertoire, and which is a fancy way of saying what you do. Not who you do, what you do. So women, so that painful penetration also occurs when women need, normal women's health care. So going for a pap test, for example, and certainly altered or absent orgasms. Some of that is because that is pre-existing for the woman, and then all the changes of treatment really doesn't help and are not, sexual affirmative at all. Rectal cancer tends to be worse than colon cancer in terms of sexual side effects. Um, so, you can see here that in men, sexual activity drops by about 25%, and for women, about 15%. And I think part of that is because, and I'm kind of joking here, as women, we just have to lie there. So, and of course, when I'm talking here, I'm very much focused on sexual intercourse, which is just part of our sexual repertoires. It's not the be all and it's not the end all. And certainly when I talk to the couples that I counsel, I tell them that is not my end goal for them. Right, they have to set their own end goal, what they want, and it is not necessarily penetrative intercourse. So I just wanted to put that in there. Um, Lack of social support is important in terms of people actually seeking help because it can be, somewhat embarrassing. Maybe they don't know that this is something where help is available. So social support is important. And in fact, um, I have a young patient. I'm a nurse. I talk about patients. I don't have clients. I have a patient. She's a young woman who I first saw in 2021. Might even have been 2020. I saw her once and she completely disappeared. There was COVID, so I thought, well, maybe that has something to do with it. But it was actually lack of funds because in private practice, I have to charge people. And she's now reappeared because her mom, has agreed to pay for 10 sessions with me, which I just think is absolutely extraordinary because it's a fair chunk of change. So, there she's got great support. She's young. Um, so, extremely common in instances of colorectal cancer is the issue of the ostomy. Now, some people are accepting they don't have a problem. There are actually instances that I have read in the literature of people actually using their stoma as part of their sexual activity. I have to admit, I have not seen a patient where that was something that was brought up, but they just might not have wanted to tell me because certainly I think some people might think, geez, that's really weird. I personally don't think there's much that is weird. We are complex creatures and, whatever floats your boat, as long as it's consensual and they're not children around. Um, we also have to take off for many of us, our heterosexist blinders, assuming that it is only men who have sex with men that engage in anal or in anal penetration or anal play. And that is actually not true. It is, there's a wide variety of men, women, gay, straight, who engage in certainly anal play, or penetration. So it's important. And for somebody who's had their anus sewn shut as part of their treatment, that removes a large part of their sexual experience. And it's often difficult to get some of our oncology colleagues to talk about it. I'll be frank. If you have an oncologist or a family physician or nurse practitioner who's willing to ask the question and talk about it, you're lucky, but it is often something that remains, unsaid, unassessed, and then help isn't available. So, in addition to sort of those physical issues, we certainly have people who, for a variety of reasons, just lose interest. That can be related to the medication that we use to treat depression and anxiety. And I just want to say a couple of things about that. I think it is absolutely normal that at the time of diagnosis and certainly going through treatment, people get depressed and they are anxious. Is the treatment going to work? How's it going to affect me? How's it going to affect my life, my partner, etc.? So we put them on antidepressants very, very commonly that in themselves cause sexual problems, primarily loss of interest, as well as inability to achieve orgasm. I have seen people who 15 years after treatment is over are still on an antidepressant, and nobody has ever asked them if they think they still need to be on it. We have to be careful about getting people off these medications, but somebody just keeps signing a prescription, and it's no longer necessary because that reactive depression no longer exists, and the person is well past recovery and into survivorship. But loss of interest is common because of body image changes and physical changes, because of exhaustion, because of, the multiple roles that we play, because of society and family expectations of who we are. So, it's quite common that interest in sexuality, or it's not sexuality so much, because sexuality is like a whole person thing, about that interest in sexual activity wanes or sometimes completely disappears. Certainly, fear of recurrence, which is related to anxiety, sort of fear of recurrence is most, we see it during treatment, certainly, because who on earth wants to go through that again? But certainly is something that we see a lot in recovery and survivorship. So, every little ache or pain, cough or sniffle, uh, you know, is the cancer back? And that fear of recurrence, for many people, is lifelong, and doesn't go away. And certainly counseling can really help with that. And mindfulness meditation can help with that as well, or rather, a mindfulness practice can help with that. And then certainly, this is a topic that is just not particularly well covered in cancer treatment. Unfortunately, I think we're moving the needle. I hope we're moving the needle. I've dedicated 26 years of my career to trying to move the needle, as 16 books, and that's a lot of butt in the chair, let me tell you. Um, I think that we're moving the needle. I've certainly spent a lot of time educating healthcare providers of all kinds, radiation therapists, oncologists, nurses, social workers. Um, but there's still a reluctance among some that they just don't want to go there. They don't want we're people. Healthcare providers are people. I know I'm a bit of a weird person in this regard because I can talk about this anywhere. But we bring our own baggage, we bring our own upbringing into the work that we do, and healthcare providers can be embarrassed. The biggest issue, I think, is that healthcare providers don't want to be seen to lack knowledge. And the amount of education that healthcare providers across the board receive about human sexuality, so healthy sexuality, as well as what is related to illness, uh, is woefully lacking. Would you believe that in medical school, students get 2 hours of education? And of those 2 hours, I think an hour and a half is focused on male sexual function and maybe half an hour on female sexual function. So, how do you expect people to be confident in asking the questions in order to provide information? So that's a huge one. Oh, here we go. So, I believe with every cell in my body that as oncology care providers, we have an absolute responsibility to talk to our patients about this. We need to warn them, or just at least inform them uh, before treatment starts about this. And listen, frankly, often people don't listen, right? Or they don't hear, right? Because what they're focused on is, will I survive? Am I going to get through all this treatment? How's it going to affect my life, my partner, my kids, etc.? So, um, they we know that after someone hears the words, you have cancer, they hear 10% of what we tell them. So, in a pre-op session, or at pre-anesthesia clinic or whatever, um, people are really focused on the here and now, and they are not focused on, or can't really wrap their heads around that life is going to go back to something resembling normal, not necessarily what life was before the cancer, but something resembling normal. Healthcare providers hate to blush, beginning, middle, and end. You can control a blush. I have blushed. And I just use it as a sort of icebreaker, as like, look at this. I've been doing this for 26 years and you made me blush. Please don't feel bad about it. I think it's kind of, a badge of honor. You made the sex therapist blush. So I think I've covered the lack of knowledge issue. The other thing that we see is passing the buck. The oncologist thinks the nurse is going to deal with this. The nurse thinks that the social worker is going to deal with this. The social worker thinks that the radiation therapist is going to deal with this. And around we go, and it just doesn't get discussed. And I think that's a real, that's a real shame. Sometimes it's your primary care provider who actually does a really, really good job because they know you, hopefully, if you have a primary care provider, and they've known you for a long time and they understand the context of your life. But when you ask most oncologists, they will say to you, and I have gone toe to toe with many, many oncologists when I've said, why did you not discuss this? Um, they'll say the focus is on treating and eradicating the cancer. And for many individuals with colorectal cancer, the focus is on survival. And the thought of being a sexual being again just, doesn't come into the equation. And I get that. I really do. But I just, sort of want to plant a little seed in your big brains that this is an issue. And I'm pretty sure that many of you know that, but just always have it somewhere, in your arsenal that just ask. And if you are reluctant to say, how's your sex life? And I understand that, have a sentence like, how's your relationship? How has the cancer impacted on your relationship? The person who you're talking with may be so shocked that someone actually asked, that they actually don't know what to say, so they don't say anything, but they may come back at a later time. And this pertains to healthcare providers as well. If you've opened the door a little bit, they might not be ready to step in, but they know that you're the door opener, so they will ask you. And I completely understand that, certainly during treatment and during that recovery phase, which can be quite lengthy for many people, all you're thinking about is getting through the day. The last thing you're thinking about is, hot and heavy sex and swinging from the chandelier. Do not swing from the chandelier. It is not recommended in the slightest. So, what can we do about this? So, I don't know why I always start with men. I really have to switch my slides around. Um, there are pharmaceutical treatments that are available for the management of erectile dysfunction, which is not the sole um, trajectory or the sole experience of sexuality. But it's something that, men do tend to focus on because in the past it's probably worked really well. And one of the concerns that I have with the recent data that we have certainly coming out of the States about young people, and I have to admit, when I think of young people, I think of someone in their 20s and 30s. I don't think of someone in their 50s. But yeah, now that I'm in my certainly 50s is young. Um, may already have encountered some sexual difficulties, certainly difficulties with erections. Um, and so that might be pre-existing, and having, a big chunk of your colon cut out is certainly not going to help. A colorectal or a GI surgeon that I worked with some time ago said to me, the surgery is slash and burn. Make no mistake about it. In men, the surgery is often very close to the erectile nerves that run on the outside of the prostate. So what we see in men with colorectal cancer is the same sort of sexual symptoms that we see in men with prostate cancer. We know very little about the sexual impacts on women with colorectal cancer because I don't know. I'm stymied. I don't know if any of you are involved in research of any kind. Just think about maybe, doing a thesis on this. Just even qualitative would be helpful. So certainly the PD5 inhibitors, which is the class of oral drugs, um, help maybe 50% of the time in individuals with cancer. And even in the general male population, only about 50% of men actually renew a prescription, which I think is quite astonishing because, these drugs, the little blue pill, etc., have become just, so much part of sort of the lexicon and people know the names, etc. Not particularly helpful, but you know what? It's a pill. It's easy to take, so often we will start there. There's also something called the Alprostadil suppository. I put it in brackets because I am not a fan. It's been around for decades. It's alprostadil, which is a type of medication that causes blood to flow to the area. So it's actually inserted into the urethra, which is the tube that you pee out of. It tends to sting, and it is so expensive, um, generally around $100 a dose. And for $100 a dose, I think the sex has to be spectacular. So I am not a fan of this, and it just actually irks me that it's still so expensive. I'm a huge fan of the intracavernosal injection. Easy for me to say, I'm a woman. So that is a fancy way of saying an injection of medication into the side of the penis when the man wants to have an erection. I see there's a gentleman that I can see watching this, and I will bet you that when I said that, he crossed his legs because that tends to happen. So we use well, not we, the man uses an insulin syringe. It's a tiny, very thin needle. Um, it works. It is not systemic. In other words, it doesn't circulate through the rest of the body. It has a local effect. It draws blood into the tissues of the penis. It's dose dependent. So for me, and I do the test doses of this, for me, to have a 40-minute, about a 30 to 40-minute erection is um, optimal as long as you inject before you get something started. Um, but men are often reluctant, but once they have a test dose and they see how well it works, they kind of get over themselves. So that ick factor goes away. Finally, there's the penile implant, which is major surgery, not always covered by provincial health plans. It's big surgery. They implant this like device into the penis. It works, but generally they can only remain in place for about 10 years and then they have to be replaced. And replacing the device is challenging for the urologist because there's scar tissue, etc. So it's often a method of last resort. There's also the penile pump, which I will tell you I'm not a huge fan of for the purposes of sexual activity. This is very mechanical. Um, there's a plastic sort of tube. The man inserts a lubricated penis into this and engages the pump. There are hand pumps. There are battery operated pumps, which are actually easier because the hand pump requires quite a bit of physical like hand dexterity, which particularly older men don't have. Um, and it's very mechanical. It sort of interrupts the flow of things. The man has to put a very tight constriction band on the base of the penis, and the penis feels cold. I once had a woman at a support group come up to me and say, when my husband uses the pump, his penis feels like a cucumber that I took out of the refrigerator. I said, "Have you told your husband that?" She said, "No." I said, "Well, you probably should have a little, you should have a little chat about it, full disclosure." Um, there's a lot of stuff out there on the internet or the interweb, as I call it. Lots of influencers, with herbs and nutrition and all kinds of stuff that is not validated. It's not backed by any kind of evidence. If someone's trying to sell you something, you can run while clicking to another screen. So at the moment, we don't have good evidence for shockwave therapy in the context of people with cancer. There is growing evidence for men who have erectile dysfunction because they get older. Once again, this is not covered by provincial health plans. It's quite expensive, not invasive. You just kind of hear this clicking sound. But frankly, until we have good evidence in the context of cancer, I would not bother spending my money on this. And pelvic floor physiotherapy, we unfortunately have very little evidence supporting this in the context of erections. Fantastic for both urinary and fecal incontinence. And if you know or see a good pelvic floor physiotherapist, yay, because they are worth their weight in gold. And gold's very expensive these days. But and not much in the area of um, erections. For women with painful penetration, is generally associated with menopause, which is loss of estrogen, which is a natural process in natural menopause, with surgical menopause, where the ovaries are removed for whatever reason, or radiation to the pelvis. Very often, if you are receiving radiation for anal, rectal, or colorectal cancer as a woman, your ovaries will be exposed to some degree of radiation, which is going to shut them down. So this loss of estrogen is going to cause vulvar and vaginal dryness. And what you most hear talked about is vaginal dryness. And whenever someone says vaginal dryness, I chime in with vulvar, vulvar. And I think the vulva is the most least used word in the English language. You kind of completely forget about that very important part of the female genitalia. So generally, there are moisturizers, there are lubricants. They are not the same. Moisturizers are for maintenance and they come in various forms. Some women choose to use something like coconut oil. Um, Vaseline actually is a really good moisturizer because it kind of occludes the tissues, but it stains your underwear and it feels kind of sticky, but it's a good moisturizer. Um, Coconut oil is fine on the outside tissues as long as you don't mind smelling like a muffin. But moisturizer should not be used as a lubricant for sexual activity. Also, please don't take the lubricant from your doctor or nurse practitioner's office that they use when you have a pelvic exam, because that is a terrible lubricant and shouldn't be, well, it's terrible in the context of sexual activity. It's fine for what it's used for like lubricating a speculum, but that's about it. There are hundreds of lubricants on the market. You just have to go into the aisle, generally where the condoms are, and you see how many lubricants there are. And it is mind-boggling and it is overwhelming. And even I have a problem. If you ever see me in, like the Shoppers Drug Mart, I'm in a trench coat with a hat on, and I'm like looking at all the boxes and the bottles to see what the ingredients are. I'm joking. I tend to just look it up online. Avoid anything that is warming, cooling, exploding, or intensifying. Those are all irritants. You don't want that. What you want is either a water-based lubricant, which is a good starting point. KY jelly is your grandmother's lubricant. Please, please, please. Not a great lubricant, full of additives. There are many others on the market. Um, Many contain hyaluronic acid, and a lot of the moisturizers also contain hyaluronic acid. Don't worry about the word acid. Um, I don't know why it's there. It's some sort of biochemical thing, way beyond my pay grade. Um, but lots and lots of lubricants. The best lubricants are silicone-based lubricants, and they will have minimal ingredients, maybe just one ingredient on the bottle, tube, or box, and it'll end in CONE. So that is a silicone-based lubricant. They stay slippery for a really long time, so they really are good. Local estrogen is the only thing that is going to address the source of the problem of a dry vagina and or vulva. It's available in multiple different formats. Speak to your primary care provider or gynecologist about this. There are creams, there's a ring that can be inserted into the vagina, which I hesitate to use the word leech because that sounds gross, but it basically provides um, estrogen to the tissues and is changed every month, I believe. Was it every 3 months? Sorry, I just drawing a blank there. Um, Generally, there is absolutely no reason why a woman with colorectal cancer should not use local estrogen. Local estrogen, so either in the form of a cream, the ring, transdermal, so it's a patch that goes onto I think it goes on the thigh or it can go on the arm, or a little pill, which is actually my favorite. It's actually, funnily enough, the same size and color as the little blue pill that men use. Um, that really solves the problem, and there is very little systemic absorption with any of them if that's something that you've been worried about. I think estrogen supplementation, or we don't use the word replacement anymore because loss of estrogen over time with age is actually a natural phenomenon. It doesn't have to be replaced, but estrogen supplementation um, is really, really helpful, but is just viewed by so many physicians as really dangerous. It doesn't cause breast cancer. In fact, we know now from, a quite significant body of research that local estrogen is actually um, appropriate and safe for use in women with hormone-dependent breast cancer. But that is taking a very long time to, get through to many oncologists. Certainly, if the woman is having other menopausal symptoms, which frequently happens, particularly for women who've had radiation or chemotherapy, because that just shuts down the production of estrogen, boom, bang. Not the gradual decline that we see with the natural menopause. So hot flashes, irritability, etc., etc., etc. There's no reason why a woman with colorectal cancer cannot get menopausal hormone therapy. It's going to make her feel a whole lot better. Um, just want to say a couple of words about dilators after radiation therapy. So, when I worked at Cancer Care Manitoba, I actually ran a program for women with anal or low rectal cancer who had radiation therapy, both internal and external, because it really does a number on the tissues of the vagina and causes the tissues become friable, which just means they're extremely sensitive, tear easily. So often these women will have bleeding, and I think nothing freaks a woman out that after intercourse or an attempted intercourse that she has some vaginal bleeding. Scary. So there's good research to support the use of dilators after radiation therapy. um, we don't have like great guidance on how often, for how long, on this, and so people sort of tend to make it up. My suggestion for patients is to start anywhere from 4 to 6 weeks after the end of radiation therapy. I don't want women to start during radiation therapy because those tissues are so sensitive. So 4 to 6 weeks after the end of radiation therapy, to start with a really small dilator. I prefer silicone dilators because they're a little bit bendy. When I actually first started working at Cancer Care Manitoba, I asked the radiation therapy staff, what are you doing about dilators? And it was mixed response. Some people said, what? And others said, oh, this is what we use. And they presented me with a tin box that had these hard plastic, they looked like candles, right? They were, sort of the two ends were cut off, the edges were kind of sharp, and honest to goodness, I just about lost my marbles. Fortunately, we had a fantastic devices department at Cancer Care Manitoba with a gentleman who worked there who never said no to me. He only ever said yes. And I went down to him and I said, "Hey, listen, we're having a problem with this dilator issue. Can you make me dilators?" He said, "Can you show me a dilator?" I said, "Sure." I had bought some for demonstration purposes. So I took one down and he said, "Oh, easy peasy," and actually used a 3D printer to make the molds and made them. And now the radiation oncologists actually use them as well. So that was a big success story. So I advise women start 4 to 6 weeks after the end of the radiation. Start small so they come in various sizes. So you want something small. Use it with some sort of lubricant. And if you are using or have been prescribed an estrogen cream, you can actually use that as the lubricant. I tell women to use it every day because then hopefully they'll use it 3 times a week. We seem to think that 3 times a week is sort of the sweet spot. If I tell a woman 3 times a week, she's going to do it once a week because that's exactly what I would do. So, 3 times a week is optimal. Insert the dilator. I suggest to women that they do it in the morning before they shower or bathe or whatever, and just get it over with. Because, like exercise, if you do it early, you've got it done. If you wait later, not going to get done because life gets in the way. You just leave the dilator in for 10 minutes, maybe 15 if you get distracted with something on your iPad or television. Take it out, wash it with soap and water, dry it with a clean towel. You're done for that time. Really, really helpful in preventing adhesions, which is a huge issue after radiation. We see the development of strands of tissue inside the vagina as the tissues heal. And once those kind of solidify, it's scar tissue. And once there's scar tissue there, there's really not much that you can do about it. I met a woman once in the States. She'd had 6 surgeries to try and get rid of the scar tissue. And honestly, she should have stopped after one because the surgery itself just caused more scar tissue. She was a youngish woman. She was a woman in her 40s. It was really quite sad. Um, what else? So if lack of orgasm, complete lack of orgasm, which we call anorgasmia. Once again, Latin. We like to hide behind Latin words. Um, so absence of orgasms, very, very weak orgasms. Pelvic floor physiotherapy, so important because the pelvic floor physiotherapist is going to assess the muscles of the pelvic floor. And most of the sensation of orgasm actually comes from contraction of those muscles. So uh, that assessment is important. If you just start doing pelvic floor exercises that you read online or somebody gave you a handout, you'll notice I didn't call them Kegel exercises because we have to stop calling things after dead white men. So pelvic floor exercises, if you just do them, firstly, most people don't do them right. Secondly, if you've already got a hypertonic pelvic floor or a tight pelvic floor, which happens, you're just going to make the situation worse. These exercises, well, a pelvic floor physiotherapist can actually teach you to relax the pelvic floor muscles, but can also teach you how to strengthen those muscles, which may, hopefully, will enhance. A vibrator can be your best friend, both internally or externally applied. I think that for people who have had um, um, radiation, women or people who have a vagina who've had radiation, using a vibrator internally actually speeds heal or can speed healing because that vibration attracts blood flow, which helps with healing. If you don't want to, use an internal vibrator, certainly an external vibrator can help, particularly for both men and women if you have performance anxiety. If you are worried about not having an orgasm, I can guarantee you're not going to have one. Now, for some people, that's a non-issue. They don't particularly care. Maybe they've never had an orgasm. Maybe they've never had an orgasm with a partner. They've only had an orgasm with masturbation. And you've got to sort that out in your own head or with a counselor. That's important. I don't believe there's right or wrong here, other than lack of consent. With loss of libido, counseling is really, really important because often what you have to do is just sort of alter the way you think about things. Um, and I've got another whole talk on the issue of responsive versus spontaneous desire, and I don't have that much time left, so I'm just going to leave that to the side. Maybe one day have me back, and I'll talk about that. Um, Important for men to know about too, right? But just essentially, many of us just walk around, wishing that we spontaneously thought about, jumping our partner. The reality is, particularly as you age, your desire for, particularly for women, becomes more responsive. So in response of, words of love, whatever sort of the floats your boat, perhaps stimulation, and it doesn't have to be genital stimulation. Maybe it's a kiss, on the side of your neck, or a back massage. All hail the back massage. Maybe that is actually where your libido kicks in along with arousal. But counseling can be really helpful here. Body image issues. This is the hardest thing for me as a sex therapist to deal with, because it's so complex. Because particularly women, but also men, right? We tend to think of men as having robust body image. That is not true at all. Um, that we come to wherever you are at with body image issues anyway. And you're either too thin or too fat or too jiggly or too wriggly or your bones stick out. I mean, I don't know. We just get wigged out about all this kind of stuff. And the truth of the matter is that your partner loves and wants the essence of you. It's not the outside stuff. So think about your relationship to your partner's body in the context of your relationship to your own body. And I'm telling you, or I bet you, that your relationship with your own body is way worse than your relationship with your partner's body. So just think about it. And certainly, a stoma is an issue. Um, the bag breaking or exploding or making weird noises or, turning your partner off. Um, a stoma therapist is, along with a pelvic floor physiotherapist, really worth their weight, probably in titanium. I don't know what that costs per ounce, but I imagine it's really expensive. Um, so, certainly they can be super helpful in terms of devices. Um, Perhaps, what you want to consider is different positions for penetrative activities that don't put pressure on the bag, or your partner doesn't see the bag and anything that's in it. So stoma therapist really, really helpful, but you've got to ask them about it because they may not tell you spontaneously because maybe you're 72 and like many people in society, which is incredibly ageist, they think that sex ends in your 40s, which I'm pleased to tell you it does not. And we have actually community research that shows us that people in their 70s and 80s are busy. They have a lot of time. Different from what they were doing in their 20s and 30s, but equally or even more satisfying. And then, of course, alternatives to penetrative activities. If penetration is a problem, either because the man has erectile dysfunction or the woman has severe dyspareunia, that nothing tends to be happening or helping, there are alternatives that are just as satisfying. So, whew, I finished 5 minutes early. I'm always happy about it. I'm now going to shamelessly self-promote myself. Fair warning. So, this is my latest book. It actually came out on February the 10th, and it's called Cancer, Sex, and Intimacy. It is available online, or you can ask your local bookstore to order it. Um, I tell stories because this is how I believe we learn. So every story or every chapter deals with a different sexual symptom. I'm not going to say problem, but often there are problems. And I tell stories of two couples in each chapter, along with evidence-based guidance. Um, this is for couples, but it doesn't mean if you're single that it's not appropriate for you, because certainly it is, and who knows how long you're going to be single. If you want to be single, go for it. If you're looking for a partner, I address that issue too of new partnerships. So I'm going to now stop with my shameless self-promotion. Oh, if you do buy it online, it is available in paperback and hardcover. Please do not buy the hardcover one. It costs $80. And I think it's actually meant for libraries, and I just think that's ridiculous. So I think the paperback is sort of in the range of 30 something dollars on um, the website where we buy everything that is owned by that odious little man. Um, and I'm at fault. So yeah, I'm done. 3 minutes early. Thank you, Cassandra.
Thank you so much, Dr. Katz, and big congratulations on your new book. I wonder if you can just stop sharing the screen.
Oh God, yeah, I
Yeah,
knew I'd forget something. There we
that's
go.
okay. Yeah, I had lost my visual. I didn't know if the audience
Okay,
had as
yeah,
well.
sorry. I knew I'd forget
Um,
something.
no worries. Yeah, so big congratulations on your new book, and
Thank
thank
you.
you so much for joining us today to talk about this again, a really important topic that is often not addressed very well through our cancer care system. What we will do now is our coaches will head backstage with you, Dr. Katz, to have our interactive question and answer session, and then we will be back live around 4 o'clock or shortly thereafter for the session with Dr. Marcelo Seipel on the surgical management of colorectal lung metastases. I have just got word that Dr. Seipel got called in for an urgent consult in the OR. So we may be a few minutes late with that last session of the day. But our understanding at this point in time is that we still are a go, and we just may be a few minutes late. So please bear with us if you are looking to join the final session of today at 4 o'clock to 4:15. And we wish Dr. Seipel's patient very well in the interim. Thank you, everyone.